Jerusalem Guidelines 2023, Acute Appendicitis Management Q&A Essential Questions and Answers for General Surgery Residents. Welcome to the Everything Surgery podcast. In this episode we discuss the Jerusalem Guidelines 2023 for the management of acute appendicitis. Today, we will cover key questions and answers to help you deepen their understanding of appendicitis care. Pause the video when you hear the word answer to attempt answering questions. Let go. Diagnosis and evaluation question. What is the sensitivity and specificity of the Alvarado score? Answer. The Alvarado score has a sensitivity of approximately 80% and a specificity of about 75%. A score of 7 or greater is suggestive of appendicitis, but is not definitive. Question. When is computed tomography indicated for suspected appendicitis? Answer. Computed tomography is indicated for atypical presentations, such as in elderly individuals, those with suppressed immune systems, or when the results of ultrasound are equivocal. Question. What ultrasound findings suggest appendicitis? Answer. Key ultrasound findings include a non-compressible appendix greater than 6 mm in diameter, wall thickening, and periappendiceal fat stranding. Question. How does pediatric appendicitis differ from adult presentations? Answer. Pediatric appendicitis has higher perforation rates, up to 50%. Ultrasound is first line for diagnosis, with computed tomography reserved for indeterminate cases. Question. What laboratory findings support the diagnosis of appendicitis? Answer. Laboratory findings include white blood cell count greater than 10,000, neutrophilia above 75%, and C-reactive protein greater than 10 mg per liter. Non-operative management question. When is non-operative management appropriate? Answer. Non-operative management is suitable for cases of uncomplicated appendicitis, in which there is no perforation, abscess, or peritonitis. Question. What is the recommended antibiotic regimen for non-operative management? Answer. Start with intravenous ceftriaxone and intravenous metronidazole or intravenous piperacillin tazobactam for 48 hours, followed by oral ciprofloxacin and oral metronidazole for 7 days. Question. What is the 1-year recurrence rate following non-operative management? Answer. The recurrence rate ranges between 15 and 30%, and is higher when a fecalith is present, reaching up to 40%. Question. When is interval appendectomy recommended? Answer. Interval appendectomy is recommended after non-operative management for complicated appendicitis, such as abscess or phlegmon, or for recurrent episodes. Question. What are the contraindications to non-operative management? Answer. Contraindications include peritonitis, sepsis, suspicion of malignancy, and individuals with suppressed immune systems. Surgical management question. What is the preferred surgical approach for appendicitis? Answer. The preferred approach is laparoscopic appendectomy, which results in a shorter length of stay and fewer infections when compared to open appendectomy. Question. When is open appendectomy preferred? Answer. Open appendectomy is preferred in cases of perforation with dense adhesions, when laparoscopic resources are limited, or by surgeon preference. Question. How should an inflamed base of the appendix be managed? Answer. Staple or resection with inversion of the stump is recommended to reduce the risk of leakage. Question. What is the role of irrigation in perforated appendicitis? Answer. Limited saline irrigation is used, but aggressive lavage is avoided as it has no proven benefit. Question. When is drain placement indicated following appendectomy? Answer. Drain placement is indicated only if there is a localized abscess that cannot be fully debrided. It is not routine practice. Complicated appendicitis question. How is appendiceal abscess managed? Answer. Management involves percutaneous drainage and intravenous antibiotics, with appendectomy delayed for 6 to 8 weeks. Question. What defines gangrenous appendicitis? Answer. Gangrenous appendicitis refers to a necrotic appendix without perforation and requires urgent surgery. Question. How is generalized peritonitis managed in the setting of appendicitis? Answer. Generalized peritonitis is managed with emergent laparoscopy or laparotomy and broad-spectrum intravenous antibiotics, such as meropenem. Question. What is the mortality rate of perforated appendicitis? Answer. The mortality rate ranges from 1 to 5%, and is higher in elderly individuals or those with suppressed immune systems. Question. How is a postoperative intraabdominal abscess treated? Answer. Treatment involves computed tomography-guided drainage and antibiotics that cover anaerobes and enterobacteriaceae. Special populations question. How does pregnancy alter the management of appendicitis? Answer. Magnetic resonance imaging is recommended for diagnosis, and the laparoscopic approach is considered safe in the first and second trimesters. Question. What are common mimics of appendicitis in elderly patients? Answer. Common mimics include diverticulitis, malignancy, and mesenteric ischemia. Question. How is appendicitis managed in individuals with suppressed immune systems? Answer. There is a lower threshold for surgery, and coverage for fungi, such as Candida, is considered for high-risk individuals. Question. What is the role of non-operative management in children? Answer. Non-operative management is controversial for children due to higher failure rates compared to adults. Surgical intervention is preferred. Question. How is appendicitis diagnosed in people with obesity? Answer. Computed tomography is preferred, as ultrasound often provides non-diagnostic results. Postoperative care question. When should postoperative antibiotics be discontinued? Answer. For uncomplicated cases, discontinue after 24 hours. For complicated cases, discontinue when the patient is afebrile and white blood cell count is normal, typically 3 to 5 days. Question. What are the signs of stump leak after appendectomy? Answer. Signs include fever, ileus, elevated C-reactive protein by postoperative day 3 to 5, and confirmation with computed tomography. Question. When is routine follow-up imaging required postoperatively? Answer. Routine follow-up imaging is only needed for complicated cases, such as abscess. Question. How is postoperative ileus managed? Answer. Management includes withholding oral intake, nasogastric tube vomiting, and early ambulation. Question. What is the risk of incisional hernia following laparoscopic appendectomy? Answer. The risk is less than 1%, compared to 5 to 10% after open appendectomy. Diagnostic tools and scoring systems question. What is the role of scoring systems such as the appendicitis inflammatory response and adult appendicitis score? Answer. The appendicitis inflammatory response is effective for ruling out disease, with scores of 4 or less demonstrating 97% sensitivity. The adult appendicitis score combines laboratory and imaging findings. Scores 16 or greater suggest surgical intervention. Question. Can trends in C-reactive protein predict perforation? Answer. A C-reactive protein level greater than 100 mg per liter at admission or rising within 12 hours suggests perforation. Question. When should an appendiceal tumor be suspected? Answer. Suspect a tumor in individuals older than 50 years, with atypical pain, prolonged symptoms, or mucocele seen on imaging. Question. How is an incidental carcinoid tumor of the appendix managed? Answer. Tumors less than 1 cm require appendectomy alone. Tumors between 1 and 2 cm may require right hemicolectomy if there is mesoappendiceal invasion. Question. What is the role of preoperative albumin measurement? Answer. Preoperative albumin levels predict complications. Levels below 3.0 grams per deciliter double the risk of surgical site infection. Surgical techniques question. What is the role of single incision laparoscopy for appendectomy? Answer. Single incision laparoscopy offers a cosmetic advantage but presents higher technical difficulty. Outcomes are similar to multiport laparoscopy. Question. What is the role of robotic appendectomy? Answer. There is no clear advantage over conventional laparoscopy, but robotic techniques may help in complex cases such as abscess lysis. Question. How does near-infrared imaging aid in appendectomy? Answer. Near-infrared imaging can identify gangrenous segments by indocyanine green uptake, but it is not routine practice. Question. When is intraoperative frozen section indicated? Answer. Intraoperative frozen section is used only if there is suspicion of malignancy, such as mucinous neoplasm. Question. What are the indications for right hemicolectomy during appendectomy? Answer. Indications include adenocarcinoma, base involvement, or tumors larger than 2 cm. Antibiotics and infection question. How should organisms producing extended spectrum beta-lactamase be covered? Answer. Use carbapenems such as meropenem or a combination of piperacillin, tazobactam and amikacin. Question. How is postoperative Clostridioides difficile infection managed? Answer. Treatment involves oral vancomycin or oral fidaxomicin. Metronidazole is avoided due to high resistance. Question. How is portal vein pilophlebitis managed? Answer. Management includes 4 to 6 weeks of intravenous antibiotics, such as meropenem, and anticoagulation if the thrombus extends. Question: when are intraoperative cultures recommended? Answer: intraoperative cultures are recommended only for perforated cases with abscess, to guide antibiotic de-escalation. Question: what is the role of fecal microbiota transplant in postoperative infection? Answer: fecal microbiota transplant is investigational for recurrent Clostridioides difficile infection following antibiotic therapy. Special populations. Continued question: how is appendicitis managed in individuals with cirrhosis? Answer: mortality is higher in individuals with advanced cirrhosis, and drains are avoided to reduce the risk of variceal bleeding. Question: how does human immunodeficiency virus affect appendicitis management? Answer: consider cytomegalovirus, Mycobacterium avium complex, or Kaposi sarcoma if the CD4 count is below 200. Question: how is appendicitis differentiated from vaso-occlusive crisis in people with sickle cell disease? Answer: computed tomography is recommended to avoid misdiagnosis. Question: how is appendicitis managed in individuals with lupus? Answer: there is a high risk of perforation, up to 40%, and steroids may mask symptoms. Question: how is appendicitis managed in transplant recipients? Answer: maintain immunosuppression and provide coverage for opportunistic pathogens such as Candida. Postoperative complications. Question: how is chronic abscess managed after appendectomy? Answer: chronic abscess is managed with percutaneous drainage and 4 weeks of antibiotics. It is important to rule out fistula. Question: how is enterocutaneous fistula managed postoperatively? Answer: management includes withholding oral intake, total parenteral nutrition, and octreotide. Surgical repair is considered if persistent beyond 6 weeks. Question: what is the risk of recurrence with a retained fecalith after non-operative management? Answer: retained fecalith carries a 40% risk of recurrence. Elective appendectomy is recommended. Question: does appendicitis increase infertility risk? Answer: there is no proven link, unless tubo-ovarian abscess complicates perforation. Question: how is stump leak managed after appendectomy? Answer: management includes percutaneous drainage or reoperation with revision of the stump, and possibly ileocystectomy. Oncology and rare pathologies. Question: how are appendiceal mucinous neoplasms classified and managed? Answer: low-grade mucinous neoplasms require appendectomy, while high-grade neoplasms may require right hemicolectomy and hyperthermic intraperitoneal chemotherapy. Question: how is appendiceal diverticulitis managed? Answer: appendiceal diverticulitis has a higher risk of perforation and is managed surgically, as it mimics classic appendicitis. Question: what is the management of gastrointestinal stromal tumor in the appendix? Answer: perform complete resection, either appendectomy or hemicolectomy, depending on tumor size and margins. Question: what is the role of peritoneal cytology in appendiceal neoplasms? Answer: peritoneal cytology is used for mucinous neoplasms to rule out pseudomyxoma peritonia. Question: how is typhlitis managed in neutropenic patients? Answer: typhlitis requires bowel rest, granulocyte colony stimulating factor, and antifungal therapy. Perioperative optimization. Question: what is included in enhanced recovery after surgery protocols? Answer: protocols include preoperative carbohydrates, early feeding, multimodal analgesia, and reduce length of stay by 1 to 2 days. Question: when is deep vein thrombosis prophylaxis indicated preoperatively? Answer: use low molecular weight heparin for individuals at high risk or undergoing prolonged laparoscopy. Question: what is the benefit of preoperative smoking cessation? Answer: preoperative smoking cessation reduces infection rates. Aim for cessation at least 4 weeks before surgery. Question: how is alcohol withdrawal prophylaxis managed preoperatively? Answer: use the Clinical Institute withdrawal assessment protocol with benzodiazepines for individuals with chronic alcohol use. Question: what is the role of preoperative beta blockers? Answer: continue beta blockers if already prescribed, but avoid new initiation due to increased risk noted in the perioperative ischemia evaluation trial. Critical care and comorbidities. Question: how does coronavirus disease impact appendicitis management? Answer: there is a higher risk of thrombosis. Therapeutic low molecular weight heparin is indicated if D-dimer is 3 times normal or higher. Question: how is appendicitis managed in individuals with chronic obstructive pulmonary disease? Answer: Optimize bronchodilator therapy and avoid nasogastric tubes, as these increase aspiration risk. Question: what adjustments are needed for appendicitis management in individuals with end-stage renal disease? Answer: adjust antibiotics and avoid aminoglycosides. Monitor electrolytes closely. Question: how is appendicitis managed in people with diabetes mellitus? Answer: maintain tight glucose control, targeting 140 to 180 mg per deciliter, as there is a higher risk of abscess formation. Question: how is appendicitis managed in individuals with ascites? Answer: diagnostic paracentesis is used to rule out spontaneous bacterial peritonitis, and drains are avoided due to leakage risk. Key statistics and mortality. Question: what are the main causes of postoperative mortality following appendectomy? Answer: the leading cause is sepsis, accounting for 50%, followed by cardiac events at 30%, and pulmonary embolism at 10%. Question: how do perforation rates of appendicitis vary by age? Answer: children have perforation rates of 30 to 50%, adults around 20%, and elderly individuals between 50 and 70%. Question: what predicts failure of non-operative management? Answer: the presence of fecalith, C-reactive protein greater than 100 mg per liter, and age over 40 years increase the odds of failure. Question: what are the conversion rates to open surgery during laparoscopy? Answer: in uncomplicated cases, the conversion rate is 2%, while in complicated cases with adhesions or abscess, the rate increases to 10 to 15%. Question: what are the rates of incisional hernia following appendectomy? Answer: after open surgery, the rate is 5 to 10%, and following laparoscopy, it is less than 1%. Rare scenarios. Question: how is appendicitis managed in pregnancy with twins? Answer: magnetic resonance imaging is recommended for diagnosis, and laparoscopic appendectomy is safe before 28 weeks of gestation. Question: how is appendicitis managed when associated with Meckel's diverticulum? Answer: both the appendix and Meckel's diverticulum should be resected if inflammation is present, and ectopic gastric mucosa should be ruled out. Question: how is appendicitis managed in the setting of Ogilvie's syndrome? Answer: neostigmine is administered for colonic pseudoobstruction, with appendectomy performed after decompression. Question: how is appendicitis managed in individuals with superior mesenteric artery syndrome? Answer: treat malnutrition first with total parenteral nutrition and avoid prolonged periods without oral intake after surgery. Question: how is appendicitis managed in people with Hirschsprung's disease? Answer: enterocolitis should be ruled out, and a rectal biopsy considered if the diagnosis is uncertain. Thank you for listening to our podcast episode on the Jerusalem Guidelines for Acute Appendicitis Management. We hope these questions and answers provide you with a comprehensive guide as you prepare for your surgical training and clinical practice. If you enjoy the content, please like, subscribe and share with a friend. See you on the next episode.